Hello, my name is Marco Niero, and I'm the CSO of CTF Europe. I wanted to welcome you to this info masterclass, and most especially thank you on behalf of all the patients for your interest in NF. Now, before we move on to the real stuff, I need to give you some instructions regarding the Q&A. You will be able to put down your questions by using the chat box during the masterclass. We would much prefer if you put down these questions in English. If you have trouble formulating your question in English, we could advise you to try to use online translators such as Google Translate before putting them down in the chat box. And if that is not possible for you, please do it in your own language, and we will do our best on our end to have it translated as best as we can into English. Enjoy your masterclass.
Hello, everybody, and welcome. I'm Rosalie Ferner from London. I just wanted to tell you just very briefly that I'm very sorry, but my friend and colleague Victor Mautner is unable to be with us this evening due to ongoing serious health problems. He sent his very best wishes for the meeting. He and I have worked together for over 25 years and collaborated on this difficult problem of trying to treat people with malignant peripheral nerve sheath tumors. So although he's not there in person, I will be referring to some of his important work. So without more ado, I just want to underscore that this is very much directed towards medical health professionals rather than patients at this stage. But I hope that you enjoy the talk. Thank you very much. We're very pleased that you've joined this education session on NF1-associated malignant peripheral nerve sheath tumors. As you know, NF1 is a tumor suppressor condition, and people with this disease are at increased risk of developing both benign and malignant tumors. Mpnst are both difficult to diagnose and to manage and treat. So today I'm going to talk to you about the risk factors for developing Mpnst, the clinical presentation, and the process for diagnosis. I will touch on treatment, which really falls within the province of the specialized multidisciplinary sarcoma teams, and I will show you our 5- and 10-year survival outcomes for our patients in London. First, you're going to travel with me to the Westminster Hospital in London. The year is 1840, and Frederick Hale Thompson is addressing an audience of male colleagues. "Gentlemen," he said, "I'm going to talk to you about an unusual case." He proceeded to recount the history of John Latham, a 36-year-old coach painter who was apparently sober and hardworking. He had had multiple tumors on his skin since childhood. He presented to Frederick Hale Thompson with a growing tumor in the right thigh that caused a violent throbbing, and it went from the size of an egg to the size of a large loaf of bread. He was admitted to the Westminster Hospital, and he was given iodide of mercury and lard with opiate. And then, when this didn't work, current state-of-the-art treatment, turpentine with sulfuric acid. Unsurprisingly and unfortunately, he died in agony 8 months later. He was found to have a sarcoma, or what we now term malignant peripheral nerve sheath tumor. Based on the Finnish study from Juha Peltonen's group, we now know that there is a 15.8% lifetime risk of developing Mpnst if you have NF1. Mpnst can occur throughout life, but are commoner in the late 20s and early 30s. In our 109 patients in London, our age range is 10 to 81 years, with a median of 29 years for developing Mpnst. Most Mpnst arise in pre-existing neurofibromas, but many of us have seen the tumors arise de novo in some cases. Victor Mountner's group found that this happened in 16% of 31 patients with Mpnst. A number of risk factors have been reported that are associated with an increased risk of developing Mpnst. How do these risk factors help in practical terms? They don't determine the frequency of surveillance required, nor the likely location or timing of an Mpnst. In simple terms, the risk factor raises the suspicion of a diagnosis of Mpnst in individuals with relevant symptoms. So let us consider the risk factors. People who've received radiotherapy for malignancy have a risk of developing Mpnst, which may occur even decades after the primary tumour. There's an association with a personal or family history of Mpnst. 8.5% of our 109 patients had a family history of Mpnst, and 12% had a previous Mpnst. About 5 to 10% of NF1 individuals have a more severe phenotype with a heavy tumour burden. This is associated with large deletions that involve the whole of the NF1 gene and flanking regions. More recently, missense mutations affecting NF1 codons 844 to 848 have been associated with an increased risk of Mpnst. There is a recognized association between Mpnst and NF1 neuropathy. The presence of a large burden of subcutaneous neurofibromas and a large lesion load of internal neurofibromas, as well as atypical neurofibromas. And I shall show this in more detail in a moment. So in the top two slides, you see a female who was treated with radiotherapy for an optic pathway glioma when she was a young child. As you know, radiotherapy is now contraindicated for this tumor. About 15 years later, she developed a low-grade parapharyngeal Mpnst and was successfully treated by surgical excision with full removal of the tumor. The picture below shows a high-grade femoral nerve Mpnst, which sadly metastasized to the lung in a 50-year-old male. He'd been previously treated with chemotherapy and radiotherapy for a non-Hodgkin's lymphoma. Sadly, his daughter also subsequently developed a high-grade Mpnst in the neck. We have encountered a number of patients with NF1-related neuropathy, and that is associated with Mpnst. The French group have had a similar experience. As you see in this patient, there are thickened peripheral nerves, pes cavus or high arch feet, associated with a mild and generally non-progressive sensory motor neuropathy that is length dependent. That means it's most prominent in the lower limbs. These patients have a high internal and external disease burden. In a whole body MRI study, Victor Mountner showed that in patients who were aged less than 30 years, all 6 patients with Mpnst had internal neurofibromas, but only 3 out of 11 of the controls who were less than 30 years had internal neurofibromas. Furthermore, the median number and the median volume of the plexiform neurofibromas was greater in the Mpnst group than in the controls in patients under 30 years. This study has led to the proposal to carry out screening whole-body MRI around the age of 16 years to look at internal tumor burden in people with NF1. There is a caveat in people who do not have internal tumours because, as I said previously, a small number of Mpnst arise de novo and not in pre-existing neurofibromas. As regards whole body MRI, further work needs to be undertaken to determine the optimal protocols and imaging frequency so that it can be standardized across different institutions. So just to highlight the different types of neurofibroma in NF1, there's no evidence that cutaneous neurofibromas undergo malignant change. We know that most Mpnsts arise in pre-existing plexiform neurofibromas, and subcutaneous neurofibromas also occasionally have malignant transformation. So let us consider the atypical neurofibroma. I want to underscore that the diagnosis is made on histology on the basis of high cellularity, atypical nuclei, no necrosis, and less than 5 mitoses per high-powered field. Because of the overlap with low-grade Mpnst, it has been suggested that the term atypical neurofibromatous neoplasm of uncertain biologic potential should be used. Eric Legis's group showed that just like Mpnst, these atypical neurofibromas showed copy number loss of cell cycle regulators, cyclin-dependent kinase inhibitors 2A and 2B. Clinically, atypical neurofibromas are difficult to distinguish from symptomatic neurofibromas or Mpnst. So with Eric Legis and Brigitte Wiedemann's group, we looked at 63 patients with 76 atypical neurofibromas and a median age of 27 years. Out of the 76, 45 were painful, 19 had motor deficit, and 45 were visible or palpable. Importantly, 13 or 17% had no clinical signs. Atypical neurofibromas appear as distinct nodular lesions on MRI, and most, but not all, were hot on 18-FDG PET. To our knowledge, atypical neurofibromas that were completely resected have not recurred. However, 4 out of the 76 transformed at some stage into Mpnst, and 17 out of the 76 were associated with an Mpnst that was located in a different part of the body. Here is a patient with a segmental form of neurofibromatosis 1 and an unrelated skin disease. He experienced gradual growth in a brachial plexus neurofibroma, and biopsy showed that this was an atypical neurofibroma on histology. Subsequently, about 2 years later, he presented with a short history of severe pain and rapid growth of the neurofibroma. And when we investigated him, he had hemorrhaged into a high-grade necrotic malignant peripheral nerve sheath tumor. Not lose sight of the individual amongst risk factors for Mpnst and protocols for diagnosis. The most important step in making a diagnosis of Mpnst is clinical evaluation of the patient. Urgent assessment should be carried out if a plexiform neurofibroma causes one or more of hard texture, rapid growth, new or unexplained impaired function, or persistent or nocturnal pain. Just to mention, 15% of our 109 patients did not have pain associated with an Mpnst, so you cannot always rely on pain as an indicator. Patient education is key to making the diagnosis, and we give our patients a card in the shape of a credit card with a list of relevant symptoms. They can phone our specialist nurses who triage them over the phone if they develop symptoms. And we find that using fruit or vegetables is helpful to help our patients assess whether there's been a change in size. So was it the size of a pea or an orange? This is very much in the tradition of Van Recklinghausen, who used pigeon feathers to think about shapes and sizes of nerves. Unfortunately, it is often not simple to make a diagnosis of Mpnst within the context of neurofibromatosis 1. It can be very challenging to diagnose malignant change in patients who have multiple neurofibromas causing symptoms. Symptoms of Mpnst can overlap with symptoms caused by benign neurofibromas or coexisting medical conditions. For instance, a patient might experience pain in the back due to paraspinal Mpnst or due to kyphoscoliosis. Hemorrhage into a neurofibroma causes a painful, hard, large mass. This can be due to vascular change of the neurofibroma, underlying vessel dysplasia, or to hemorrhage into a malignant lesion, as I've shown you just now. Pain from an Mpnst can erroneously be mistaken for a banal problem. If you've got a large heterogeneous Mpnst, blind biopsy can miss the site of a lesion. So here to illustrate the points, you can see two large, firm, symptomatic plexiform neurofibromas. The one at the top was a benign plexiform neurofibroma that was resected, and the one below was a high-grade malignant peripheral nerve sheath tumor, which subsequently metastasized. This patient presented with a painful, enlarging plexiform neurofibroma in the upper limb, but this was due to an underlying artery dysplasia and not to malignancy. This NF1 patient had an enlarging, painful, hard right elbow mass. Unfortunately, it was treated as tennis elbow or epicondylitis with steroid injections, and the patient was not referred to us for 18 months. And so the diagnosis of high-grade malignant peripheral nerve sheath tumor was delayed. So we've thought about the clinical symptoms that could be suspicious for an Mpnst. Examination, of course, can reveal a painful hard mass, but not all lesions are palpable or visible. Examination can show you a neurological deficit, breathing, swallowing, or sphincter disturbance that can give a clue to the location of an internal tumor. As I've mentioned, whole body MRI can play a role in surveillance, but once a patient is symptomatic, regional MRI is the modality of choice to show the location and size of the tumor. And many units, including ours, use volumetric analysis to look at growth. However, MRI does not reliably diagnose malignancy. Our neurofibromatosis service was the first service to use 18-FDG PET to assist in the diagnosis of NF1-related Mpnst. Subsequently, we've used 18-FDG PET with CT, and more recently, many institutions are using PET MRI, which has less radiation. So PET is a dynamic imaging technique that is both qualitative and semi-quantitative. It uses a standard uptake value, an SUV, that is a reflection of the regional metabolic uptake of glucose. However, I've written and shown a Tower of Babel because one of the problems is that different institutions have different scanners, software, imaging protocols, SUV cutoffs for malignancy, and it's very difficult to compare PET results across institutions. This beautiful young woman was our trailblazer. She presented in 1997 with a painful weak hand due to a brachial plexus lesion. And this is the first FDG PET scan that was done in our unit. And it showed high-grade Mpnst that was in the left brachial plexus. This young patient presented with a hard, large neck mass, swallowing difficulties, and severe pain. The 18-FDG PET-CT scan showed the hottest part of the lesion, as you can see in red, and lower grade areas surrounding it. This can demonstrate to you how PET can be useful in guiding a targeted biopsy to the hottest part of a lesion. Management of NF1-related Mpnst remains a complex and problematic undertaking. It is essential that individual patients are discussed within an expert sarcoma multidisciplinary team, where the team have experience of NF1. The ultimate aim is complete excision of the Mpnst with tumor-free margins, and that may mean amputation in some cases. Unfortunately, complete excision with tumor-free margins is not always achievable. Biopsy can be of value in large or deep-seated tumors, and as I've shown you, biopsy with 18-FDG PET can guide the biopsy to the hottest part of the lesion. Radiotherapy is used for local control in high-grade, incompletely excised or large Mpnst. Some institutions use radiotherapy to reduce the size of the lesion prior to surgery. Chemotherapy is used for metastatic or inoperable Mpnsts, usually initially with the cytotoxic doxorubicin or epirubicin and ifosfamide. Some lung metastases are amenable to surgical excision. Within this, one should not minimize the importance of psychosocial support for patients and their families. In our unit, this is undertaken by our clinical nurse specialists, clinical psychologists, and a psychiatrist when needed. Here you can see what happens if you cannot fully clear a tumor with tumor-free margins. This patient presented with severe pain, worse at night, on the outer border of the leg, and he had surgery for a low-grade L5 Mpnst. Their margins were not possible, and the tumor recurred as a high-grade Mpnst after a short interval and proved very difficult to treat. Here you can see the 5 and 10-year survival for our patients in London with NF1-associated Mpnst. 80% of our patients have high-grade Mpnst. You can see at 10 years, the survival is around 61%. So I've highlighted that NF1-associated Mpnst are difficult to diagnose and to treat and may presage a poor prognosis. So it's really important that if a patient with NF1 and a plexiform neurofibroma develops new or unexplained rapid growth, pain, change in texture, or impaired function, this patient should be suspected of having Mpnst and assessed rapidly. It's imperative that expert multidisciplinary teams should manage patients with NF1-associated Mpnst. So what are our goals for the future, and what are we doing at the moment? Well, the standardization of diagnostic imaging is really important, including whole body MRI for surveillance and PET imaging protocols, because this means you can compare across institutions. With our improving knowledge of the molecular landscape, clinical trials are now being directed towards targeted therapy and exploring the use of combination therapy because the range of cytotoxic therapy and radiotherapy is limited. Above all, what we need are robust clinical and patient-focused outcomes, so we're not just concentrating on length of survival, but quality of life for patients suffering from this very difficult disease. Thank you very much.
Well, thank you, Rosalie, for this lovely talk. I'm Marco Nievo. I'm back online now, and I'm here to take your questions. We have a first question coming from Robert Listenik. Can you comment on the necessity of a delayed PET imaging? Many units with whom I've discussed do only this, do 1 hour imaging.
Thank you, Bob. Very nice to hear from you remotely, if not see you. I think this is an important question, and hence the Tower of Babel. Our initial studies showed that we got the best separation between benign and malignant at 4 hours, and that was with FDG PET. But we have just looked at our cutoffs, and actually we feel that we haven't got a huge amount of improvement with the current scanners and the current protocols at 4 hours rather than 1 hour. So I think the difference is down to what I've said: different protocols, different scanners, PET CT, PET MRI. So what we thought initially, I think, is now not necessarily being borne out. So I think we're still doing it at 4 hours, but I think 1 hour is reasonable. I think one of the problems, Bob, is that it's very difficult to look at the PET in your institution and our institution and have equivalent results. And therein lies the problem, that we need the standardization, but it is a very important question you've raised.
Still another question from Robert. What's the role of diffusion-weighted MRI in complementing or supplanting PET imaging?
Yeah, I mean, I don't have personal experience of it. Some units are using it. I think it's going to be a combination of things. I don't think there is one at this moment. There is no one imaging modality that is perfect. And I think the El Dorado will be, I think the Mass General are trying this as well, is AI, looking for markers from large cohorts of patients to see if there are any clues on MR, diffusion imaging, or PET that actually give you the markers that somebody's got Mpnst. So yes, it is used by some units. I don't think there's one modality at the moment that is the main one.
Okay, still in the same subject as standardization of PET scans, we have a question from Lars Eriksson. For standardizing SPECT scan results, have you looked into translation of results from different institutions into standardized MRI ontology JSON format?
Sorry, I didn't get all of that. Could you, first, have we looked at what?
Have you looked into the translation of results from different institutions into standardized MRI ontology formats?
It's something that for MRI or PET or both?
For PET.
For PET. It's what has been suggested, and it is obviously the way forward. I think what's changed is the new scanners. Some people are using PET CT. The SUVs have not been worked out as well for PET MRI, but a lot of people have moved over to that because of less radiation. I think it's really important going forward that there's a European venture to try to standardize what we're doing, because it becomes very difficult to manage across institutions. As Bob has pointed out, we haven't even agreed on the timing. We haven't agreed on whether we should do qualitative using liver uptake as the standard, or whether semi-quantitative. So I think there's a lot of work to do, and if anybody wants to spearhead the study, I think it would be a great initiative.
And still on the subject of PET, a question from Oroya Mostafavi. Do you follow up PET after chemotherapy to see the response?
No, I think some institutions have been doing that. If you're using PET-CT, one's mindful that if you're doing very regular PET, you're giving a reasonable amount of radiation. Of course, you balance it against need. We do it according to patient need. So if you've got somebody that you feel has had chemo, so we've had somebody just recently, and they've developed new tumors, we would then, or our colleagues in the management side, would then do further PET. We don't have a protocol for doing it at a regular basis. There are some units that do this. So I think, again, it highlights that there are different protocols for different institutions. Certainly, if you think somebody has developed new recurrent or metastatic disease, it's not an unreasonable thing to do. Of course, you can use a CT of chest, which is pretty reasonable if you think you've got lung metastases. So again, I think I'm highlighting the Tower of Babel. It's very much institution dependent at the moment.
Thank you, Ross. A question from Suvik Karmakar. I'm curious if there are any known immune suppressive marker for this type of tumor.
Well, I'm a humble clinician. I mean, there are certain markers that are being looked at. People obviously looking at things like TP53. Through Eric Lechius's work, we've looked at the cell cycle regulators, CDKN 2A and B, because there's some markers there. And when you've got the whole gene deletions, they take out PCR2, so with SUS12. So and that basically affects your repression of replication through changing your methylation status. So, I mean, there are a lot of biomarkers of interest and possible targets that people are looking at. But as I say, I am not, I'm a clinician.
Thank you. A question from Claudia Santoro. Which are the most important predictor factors for long survival rate out of complete excision in your experience?
That's a really difficult question. And I mean, I think it will go back to the underlying molecular changes. We have a patient with absolutely documented high-grade Mpnst who has survived over 30 years, but had people have always said it's complete excision with wide margins that is the predictor. I think it's going to be the underlying molecular changes. If you've got I don't know, if you've got a P53 mutation and you've got a similar tumor, the feel is that some of these patients are going to die quickly. And when we look at our cohort, which is it's just over 100 patients, what we're seeing, and I don't pretend I understand it, is that there is a group of high-grade tumors where the person is dying within 2 years. But then if you looked at our 10-year survivals, we've got a 60% 10-year survival. So there are a number of people that are surviving longer term, not all disease-free. But is that because they've these people had wide margins. I don't think so. I think it is the underlying molecular change, but that hasn't been fully characterized yet.
And on the subject of margins, there's a good question from Lisa Woolrich. If a tumor develops within a pre-existing plexiform and is surrounded by a benign plexiform, should the clear margins be within the benign plexiform if it is extensive?
Well, I'm probably not the best person to answer that question. We certainly would fully remove it. And if it's fully surrounded with, from what I understand, if it's got a capsule around it, and you've removed it, you should be okay. But if there's a surgeon here that wants to correct me, feel free. If there isn't an intact capsule around it, you've got to ensure you've got wide margins. But this is probably highlights what I said. I'm a neurologist, and my expertise is probably in diagnosis, but I'm just part of a very large multidisciplinary team. I think I wanted to emphasize that you really can't work alone. So we work alongside oncologists, surgeons, radiologists, psychologists, the lot. And each person plays their part. So a question like that will be answered by the specialist in that team, if that makes sense. I'm not trying to dodge the question, but I think I'm trying to say that each person has their part to play.
We have many questions regarding MEK inhibitors. They all relate to, they're from Lars Eriksson and from Ana Paula Fernandez. They relate to, do you consider using selumetinib after treatment, after surgical treatment in an Mpnst? And from Ana Paula Fernandez, she'd like to know if you'll consider selumetinib also in a patient who has 2 previous Mpnsts treated and now is free of disease but has multiple internal neurofibromas growing.
The simple answer is no. Again, coming back to the team, I've had this conversation with the treating oncologist. We don't use MEK inhibitors in this context, so that's the context of people who've got a malignancy as a single agent. I think there are people who are combining mTOR inhibitors with MEK inhibitors. So I understand this as a very basic level, like if you've been to England, the English underground system, if you block one line, so you block your MEK inhibitor, it can still go down the mTOR line. So you're trying to block more than one pathway. Do we use selumetinib in people who've had previous tumors? No, we don't, because we use selumetinib judiciously in people with symptomatic tumors. I think it's really difficult, and I've come back to outcomes. It's very difficult to use a drug in this context because you don't really know what would have happened in the natural history. So if you've got somebody with a past history of malignancy and benign internal tumors, what are you actually measuring? And is this an adult or a child? And are you measuring for status quo? Or so in people without symptoms, I think it's very difficult. So the answer is no and no.
And still on the subject of treatments, a question from Lorena Baroni, who would like to know if you have experience with sirolimus in these tumors at all.
So interestingly, the simple answer is no, but we had a patient who, with NF1, who at the same time developed renal failure from an unrelated nephropathy and an Mpnst. So we were in a bit of a bind about how to treat him. And in the end, after much debate, we treated the Mpnst. It was removed and he was given radiotherapy. And then he had a renal transplant and was given sirolimus as part of the the renal transplant post-operative protocol. And on my N of 1, he's done extremely well and not developed any other benign or malignant tumours. So the simple answer is I don't personally, our units don't use it, but. I can't hear you, Marco.
Can you hear me now? Sorry.
Okay.
Yes, there are many questions coming in relating to biomarkers. What is your opinion, experience in using cell tumor DNA as an early diagnostic tool for Mpnsts in NF1?
Yeah, I have no experience of that. I'm sorry, I don't know. If they're interested, I can put them in touch with somebody.
And we have a question from Julia Olanda, who is a patient parent, would like to know if there's any medicine for prevention of Mpnsts.
Well, we would love to have that. That is the goal, isn't it? I think the initial way forward is looking for I think you've asked a very difficult question, because I've thought very long and hard about these risk factors. And I think it is important to know about risk factors. But when you're actually in the clinic and you know that certain things raise a risk of somebody having an Mpnst, I'm not sure how, and people may disagree with me, but I'm not sure how much that helps me. Does it tell me I should rescan in 1 month, in 3 months, in 6 months? It's very, very difficult because we've been wrong. We've scanned at, say, 3 months, and then 3 months later, somebody's developed something. So I think it is about, I think the Mass General's imaging AI study will be very interesting, and the El Dorado is these markers that might tell you that this patient will definitely get a tumor. But having these risks and markers is very difficult. So no, there isn't anything at the moment, but obviously it's what everybody would like to have.
And still talking about something quite similar, Juan Sebastian Botero would like to know if there's any knowledge on the possible causes why missense variants of the 844, 848 codon might be causing severe phenotypes.
I don't know. I don't know why that should be. I don't know.
And another question from Maria Kurnikova. Is there any difference in survival rate between children and adults with an Mpnst?
Yeah, it's an interesting question. I don't think there's evidence of it, but we have a unit that looks after children and adults. We are an NF unit within neurology, so we are not, although we link with 2 big sarcoma units. But the point of telling you all that is, so we're not selective just for sarcoma. So we have, I'm pleased to say, very few people under the age of 14 with NF1-related Mpnsts. Unfortunately, the few children that we've had have had a poor prognosis, but I don't deal directly with children. I deal with adults and children. I think it's a difficult thing because if you go to a pure cancer unit, they're selecting for cancer. So I don't have enough data because we have, I'm pleased to say we've got few children. So I don't think there's a difference, but the ones we've got have done more, done worse, unless anybody else has a different experience.
We have a very long question from Federica Chiara, who would like to know basically if if you think that combining MRI and PET data might be more relevant, because she thinks we need to look at indicators of metabolism based on the oncological experience of high-grade tumors.
Yeah, well, people are doing PET MRI, people are looking at MRI, they're looking at things like textual analysis. I mean, I've really concentrated on FDG PET because it's what most people use. We and Scott Plotkin's group, we dabbled with methionine, thinking that that might help us look more at cell proliferation and lower grade tumors. So you can look at different traces. There are a lot of different traces. So yeah, I mean, in effect, it is combined. At the moment, I think we're using multi-modalities. The other feel is that the disease is quite varied clinically. So I'm seeing people, a sort of small cohort of patients, and I can only speak from 20 years experience. So as a clinician, nothing clever, but you certainly have a small cohort of patients that behave. It's not very difficult to make the diagnosis. They come along, they've lost a lot of weight, they've got a very hard growing lump, and they're clearly got a high-grade tumor, and it metastasizes quickly, whatever you do. And then you have these people, and we've watched people where we haven't been able to excise the tumor because it's been inoperable. And we've watched somebody who had a low-grade Mpnst on biopsy. It wasn't operated on, it wasn't operable. And this has gone 7 years and has now transformed. So they're all behaving at slightly different rates. And then you've got people with high grades, they take them out and they've never had another problem. So I think we're very much focusing on imaging and different biomarkers. But within high grade, we have enormous clinical heterogeneity, and I don't think that's been teased out. So yes, we do use both, but I think I would say this because I'm a clinician, but I don't think we've thought clearly enough about the clinical markers as well as the radiological indicators.
Well, this was the last question we received from the audience, but I actually have one question for you. And I was wondering if you think that anything more should be done for educating around the atypical neurofibromas, and what kind of research do you think is most important that is most important now at the moment around atypical neurofibromas?
Yeah, it's a difficult question because it isn't a clinical diagnosis. If you really tease it out, you can get some suspicion. So I saw somebody just a couple of weeks ago. So what we showed, and Eric Lehis's group showed, and Birgitte as well, Birgitte Wiedemann, is that if you look on MRI, which your last person was asking about MRI and PET, these are often, but not universally, nodular lesions on MRI. And somebody asked before about removal of an Mpnst within a plexiform. We and others have seen within a plexiform on histology benign, atypical, and malignant lesions all together in the same tumor. So if you reel back, what are the clinical features of atypical? Well, actually, sometimes they're none at all. They're asymptomatic. You've taken it off because the patient doesn't like the look of the lump, and you look at it and you're surprised to see it's atypical. By atypical, I do not mean degenerative. I mean high cellularity, atypical nuclei, and a couple of mitoses, but not high numbers. So could any could clinical things help you? Well, I did see somebody just recently, and they had a painful, fairly slowly growing lump, and it was firm but not hard. So it was almost at one end of the spectrum. Could I be certain clinically that that was atypical? No, but it's a hunch because it's not as severe. So if you do a PET scan, most of these are hot, and for Bob Listening, hot at 4 hours on delayed imaging. But Vicky Warby, working in our unit, looked at the mean SUV, so standard uptake values, at 4 hours for benign, atypical, low and high grade malignancy. And they could see differences between those means. So it's on the continuum. You've got benign at one end, atypical, the SUV was a bit higher, low grade higher still, and high grade even higher. You say, well, PET can help you. Well, unfortunately not, because those are means, and there's variation around the mean. So the only way you can do it is on histology. So it is clear, and all the units that I know about who've removed these tumours, and going it back again to your previous speaker, even if they don't have wide margins, if they've been completely removed, none of us have seen these recur. So a small number, and we've seen this, I showed you one in the brachial plexus, it wasn't operable. So it's usually in the brachial plexus or pelvis. If they're not operable, you can't remove them. You've got to sit people there and watch them. And a small number do transform, but not all of them. So I think it's a very difficult question, because although Eric's work has shown that the ones he's looked at a molecular level have got the same cell cycle regulator changes as Mpnst, it is clear that only a small proportion transform. So I think it is about seeing if we can get some more help on imaging. I know Birgitte Wiedemann's group remove anything that looks nodular on MRI. And again, I'm going to refer you back to that very nebulous, but I think quite useful way of thinking about clinical features and teasing them out a bit more.
Thank you, Ross. Before we have before I ask you two more questions that have actually come in, I need to tell there's a participant who raised his or her hand. I'm afraid we can't let you in, but in the seminar. So I would ask you to put your question down in the Q&A box or in the chat box. Thank you. A question from Hans Schuheiber. Would an increasing SUV index be concerning?
Yeah, so again, we're raising this very important question. So if I'm talking about my unit. If I have a patient with a symptomatic lesion, and this is literally the London unit, if I have an SUV at 4 hours under 6, I'm going to think that is benign. If it's over 8, I'm going to have a suspicion of malignancy. And if it's between 6 and 8, that's a sort of overlap where I've seen false positives and false negatives. So this is London only, so it comes with a health warning. If I do a PET at, say, 4 hours, and that SUV is, and I've seen somebody just recently, the SUV was around 8, and then I wasn't quite sure, and I repeated it, and the SUV was 10. So that was concerning. The patient's gone for biopsy. So yes, I think it's an important question, because I think change in SUV is actually quite helpful. Is it perfect? No. So I've been rather nihilistic because I've just seen so many problems with everything we've used. I mean, you know, I think it's a combination of MRI, PET, potentially diffusion weighted imaging, as Bob mentioned, and above all, clinical skill and patient education.
And I think the last question from Lavinia Dobrea, do you have an imaging guideline to determine if, when, and who would most benefit from treatment?
I'm not really sure I quite understand the question. I mean, if I have a patient with symptoms, I will do a regional, so MRI, to look at the size and extent of the patient, of the tumor. And then I will do, not always, but mostly, an FDG PET CT to look at the uptake. And I've shown you in the imaging a heterogeneous lesion. And I think PET is particularly useful if you're trying to focus in on the hottest bit of the lesion. But ultimately, it's the biopsy. I mean, PET is only a guide. MRI, diffusion weights, they're all guides. And the gold standard is histology. So unless you've got a biopsy or the tumor, you can't really dictate what's going on. So biopsy and histology are the gold standard, really, aren't they?
A question from Annette Backer, who thinks that it's fascinating to hear that so few atypicals actually turn malignant. Has anyone done molecular analysis on the ones that don't turn malignant? And would you expect them to have a different molecular profile?
It's a really, really interesting question, because when I think back to the study that we did with Eric Legis, 4 out of 76 transformed. Now, I would have to go back and check this, because it was a question I asked him, because I said, I don't think all of ours are transforming, and that's what sort of prompted the study. But I think that he did his, I think the ones he did were mainly positive, even if they didn't transform. But I'm not, I'd have to go back and check on that. It's something that intrigues me too, and you've prompted me to just go back and check exactly. It was about 6 or 7 years ago we did the study. He was of the view they all had that molecular change, but I think it's a good question.
Well, thank you, Ross, and thank you all attendees for attending this this webinar, which is about to finish now. It's almost 2 minutes to the hour. I just wanted to take this opportunity to remind all participants that we have 2 more webinars coming up. The next one will be on November the 9th on orthopedic manifestations, and the next one and the one after will be on December the 10th on pediatric gliomas in NF1 patients. This webinar is now over. I hope everyone has enjoyed it as much as we have. And thank you again, Rosalie, for being with us today.
Thank you. It's nice to meet you all, if remotely.
Bye-bye.